Hi, my name is Ashley. The news article I'm going to be discussing today is called How Your Brain is Wired to Just Say Yes to Opioids. This article goes in depth on how opioids affect the brain, and when the patient receives the opioids, it affects the reward center. Over time, it takes more of the drug to feel the same effect as the body becomes desensitized to it. The article also goes on in depth of what happens when the body is used to receiving the opioid and then does not. The body will exhibit withdrawal symptoms in an attempt to get the body to receive the drug again. Those symptoms can be anything from nausea, muscle cramps, anxiety, to even worse pain due to the withdrawal. The opioid crisis has affected my area of work as oncology patients often receive narcotics. Specifically on BMT, we typically treat pain with only opioids. We avoid the use of NSAIDs and Tylenol as it can mask a fever. Our patients are neutropenic, so recognizing a fever is imperative to start the sepsis protocol and improve their outcomes, as if a fever is missed, it can be detrimental to their health. In my practice, mucositis is a common pain that our patients have. The pain is either from high-dose chemotherapy or as a result of a stem cell transplant, specifically auto transplants, which are the person's own cells, or allogenic transplants, which are somebody else's cells. The preservative that causes mucositis in the stem cells when they're frozen and then given back. Mucositis is graded from grade 1 to grade 4. Grade 1 is simply just redness in the mouth. Grade 2 is some ulcers in the mouth, but the patient is still able to tolerate PO pills and able to swallow food. By grade 3, the patient is unable to swallow any food or pills or tolerate anything by mouth because of the severe ulcerations and extensive soreness in the mouth and throat. By grade 4, the lining in the mouth and the throat is sloughing off. At this point, they're also unable to tolerate anything PO. The non-opioid pain management I chose to talk about today is called pilifermin. Pilifermin is specifically designed to target epithelial cells, which are what your mucous membranes are made of. This can help decrease opioid dependency, as patients with mucositis are typically put on patient-controlled analgesic pumps, otherwise known as PCAs. Our drug that is typically in those PCAs is Dilaudid, and that's a very strong opioid. It is not uncommon for these patients to be on PCAs for days to weeks, depending on the severity of the mucositis. With this drug, this could replace the PCA. This drug would be taken 3 days before treatment and 3 days after treatment. So if a patient has a stem cell transplant on Wednesday, the drug would be taken Sunday, Monday, Tuesday, not on Wednesday, and then continued Thursday, Friday, and Saturday. A benefit of this versus an opioid would be that the patients would not experience the negative side effects that opioids typically bring. Our patients tend to experience more nausea, constipation, and the drowsiness from the opioids, and most of them are not a fan of that, as they're going to have additional medication to combat those symptoms from the drug that's treating their pain. The pilifermin may be able to decrease the patient's length of stay in the hospital, as one of the barriers to them going home typically is mucositis, as we don't send patients home on PCAs. They need to be able to tolerate food by mouth. And also, mucositis is a big infection risk for our patients as they're neutropenic. This drug would also reduce the chances of the mucositis developing into the more extensive stages, such as grade 3 or 4, and would improve their quality of life ultimately during chemotherapy or after transplant. Many of these patients have said that this is the worst pain that they have been through any of the treatment. This drug is an endogenous keratinocyte growth factor, and it speeds up the healing of the epithelial cells and can prevent the mucositis from happening altogether. This would have to obviously be okayed with the oncologist and pharmacist, as there are many drug interactions with the chemotherapy and post-transplant. Some drugs are contraindicated. My targeted audience would be any patient that is going to be receiving an auto transplant or a frozen allo or beginning high-dose chemotherapy. My overall goal would be for these patients to at least consider this as a non-opioid form of pain relief to try. My learning objectives for each domain would be cognitive. The patient would judge whether this would be an acceptable pain alternative by the end of the visit. The patient would be able to name 2 benefits of this drug, such as reducing the use of opioids, eliminating it, being able to leave the hospital sooner as their mucositis would not be as extensive as it was. Effective, the patient would receive the pamphlet and be accepting of that by the end of the visit, and the patient would be able to name a possible barrier of the drug by the end of the visit. In the studies that I've read, the palifermin is sometimes tricky to have insurance approved, but when you look at the cost of the palifermin versus the cost of additional hospital stays, additional needs of narcotics, it would actually be cheaper. The psychomotor goals would be that the patient would be able to look up more information about this drug on their own and call the provider if they have any unanswered questions within the next week prior to starting treatment, as this would be something that would have to be started, like I said, before their chemo or before their transplant. I would evaluate if learning has occurred by if the patient is able to identify any benefits to them of taking the palifermin and verbalizing if they think it would be beneficial. Effective learning will have occurred if the patients accept the information and would be willing to share possible barriers. Psychomotor learning will have occurred if the patient is able to look up information and contact the provider if there are any questions. A lot of patients can be apprehensive into starting a new treatment, as there can be fear of, well, what if this doesn't work? What if I'm in pain? What are the additional side effects? With the palifermin, there are not a ton of side effects that I was able to find. Most of the side effects, obviously, allergic reaction, chills, joint pain, but overall the side effects are minimal compared to having to tolerate the mucositis longer, and ultimately these side effects would go away once the drug would be stopped. I really think this could be beneficial to our patients, as they could eliminate the use of the PCA to treat the mucositis. This could possibly completely eliminate the mucositis, and when patients have multiple rounds of chemo, this could be an option as to where they're not going to become dependent on opioids and not have to go through the period where we're having to wean them off and where they may experience withdrawal symptoms, even if they're just mild. I really think that palifermin would be a good drug of choice in combating mucositis with the bone marrow transplant patients.